right, here we go with lecture 4. All right, lecture 4 is going to go over chapter 6, which is fetal situs, chapter 7, the cardiac chambers, which you need to know well to figure out cardiac situs. Son of a. All right, here we go with lecture 4. We're going to go over chapter 6, which is fetal situs, 7, cardiac chambers, and then we're going to talk about abnormal heart position, and then the fetal heterotaxy syndrome. So clearly these are the chapters that are all related to each other, and it's helpful to know the first two to figure out the second two. So when we're talking about fetal situs, means how things are arranged when we're talking in a left and right status. The one thing that you'll hear over and over again is the first step in evaluation of the fetus. This isn't even necessarily echo. This is evaluation of the fetus is the assessment of situs. Normal situs is called situs solidus, solidus meaning common. Now, this is something that we'll go over and over through this next bunch of lectures. But in general, there is a segmental approach to fetal echoes. And the segments that we're talking about are the veins that are returning to the heart, the atria, the ventricles, and then the outflow tracts, the arterial trunks. And basically what we're going to do is assess the anatomy, normal or abnormal, position and connection of each set. And the thing that's important here in the table at the right is that it starts out with identifying the fetal abdominal and thoracic situs. And even more specifically, identify the fetal abdominal situs. So even though we're going to do an echo, we're going to look at the heart, we are going to start with the abdomen. Well, very early in embryologic life, each segment has a left and a right side. Now, what really is the left and what really is the right are recognized by the morphologic structures, what they're made of, their actual components that makes them left or right. And that's really what determines left and right, the way they're formed, not by where they are. For example, there is a true right ventricle, a ventricle that has a certain shape, characteristics of it, a certain valve that goes with it, and it doesn't matter if it's on the left side of the fetus. All right. Well, once you establish visceral and cardiac situs solidus, meaning the visceral situs is normal and the cardiac situs is normal, then you can start referring them by location. So once you've figured out that everything's normal, then you can start thinking in terms of, okay, this vessel's coming from the more anterior ventricle, and I know that the anterior ventricle is the right ventricle. But you can only say that once you've figured out that this is situs solidus. Technique for determining situs. Well, the first thing is you have to determine the fetal left and right. And here's a little exam tip that I've figured out from looking at a bunch of these mock exam things is whenever they say the first step, what they really are saying is the first step out of the 4 choices that we give you. So if you know, just because you saw this lecture, that the first step in determining fetal situs is determining the visceral situs, check around the other choices before you go with that, because they might throw in something like determine the fetal lie, which you need to do, or something like introduce yourself to the patient. So they may trip you up there. The point being, when you read first step and you're thinking determine visceral situs, still read the rest of the questions, or choices, I mean. Next thing, determine the fetal lie. And this method of determining the fetal lie is what it says in the book and what it says in these exams. I guess the way they do it is the way I do it. I just actually didn't think about it that much. But first thing you need to do is figure out what the baby's lie is. So the lie in obstetrics is really the fetus's relationship to the mother. So a longitudinal lie means that the fetal spine is parallel to the maternal spine. So yeah, first thing is sagittal view of the fetal spine. And then you'll basically look at your probe and see how that is in relationship to the mom. So the two longitudinal lies are either head first or butt first. Transverse lie is when the fetal spine is perpendicular to the maternal spine, and oblique is somewhere in between. For some reason, what they say is determine the left side of the fetus. It's probably just a good habit to get into doing things the same way every time. So you've picked the spine and then you move back and forth and figure out which one is actually the baby's left. And then what you do is you figure out where that left side is in regards to the mom. So if you figure out, okay, the left side, oh, it happens to be the one that's right beneath the transducer. It's against mom's anterior abdominal wall. Then you'll know from then on that the left side is the anterior side of the mom. Now, obviously, that can change with fetal movement, but you at least need to start that way. And then when you get all confused, that's always a good thing to do is just stop, dead in your tracks and do it again. Baby's all over the place and now you're all confused. Stop, go back to the sagittal view, figure out what really is the left and right. Is that left side, against the mom's right side, or is it anterior, or is it the left side, or is it the back? Then, once you've figured that out, you turn 90 degrees from sagittal to axial and determine the visceral situs. Now, that seems like a ridiculous thing to say, but I've seen it on multiple questions where they actually ask that. Once you've gotten the baby's left and right by a sagittal view, then what do? And the answer is you turn 90 degrees so that now you're an axial view and you are down in the abdomen. The upper part of the abdomen, the part of the abdomen that is just beneath the diaphragm, just beneath the four-chamber view. And what you should look at is look at the stomach's position, but really the main thing is this position of the aorta and IVC. That's the real thing. So you see the midline, and the aorta basically sits right on the vertebral body there, and it is slightly to the left. So by the time it's at the upper abdomen, that's where it is. It's slightly to the baby's left. And the inferior vena cava is to the right, and it is anterior. It's, well away from the vertebral body. And the reason for that is, even though it started back at the vertebral body when it was down at the level of the iliacs, by the time it gets up to the heart, it's anterior because it's going to drain into the right atrium, which is the more anterior chamber of the two atria. Now, let's talk about fetal cardiac position. Position is different than axis. Axis is which way it's pointing. Cardiac position is where it's actually located. So in normal situations, if you draw a line from the middle of the spine to the middle of the sternum. Now, sometimes the sternum's not that obvious. The clue you can get is if you look at the rib on each side, know that you have to be about in the middle between those two. You're just as close to one rib tip as the other rib tip. So normally the heart kind of sits in the middle, at least where the crux of the heart is, but 2/3 of the heart mass is in the left chest. Levocardia is when the heart is mostly in the left, and that's what's normal. So levocardia, levo meaning left, that's normal. That's where the heart is, mostly in the left chest. Dextrocardia is where it's mostly in the right, and mesocardia is where it's dead set in the middle. All right, now cardiac axis is a different thing than cardiac position. What you do is you take the interventricular septum and compare it to midline, and midline being sternum to spine. Now keep in mind that the cardiac axis is the same throughout gestation. It's 45 degrees, ideally, plus or minus 20. So that is, basically 25 to 65 is considered normal. All right. In the summary at the end of that chapter, I just really want to emphasize this, that the first step in figuring out the situs of the fetus is, once you've figured out the left and right, then figure out the fetal visceral situs. So again, you're there to look at the heart, but you start with visceral situs, upper abdomen. Let's talk a little bit about the cardiac chambers. All right. Well, we already said that step 1 is figuring out the situs. We figured out the left and right, then we did visceral situs, and then cardiac situs last. All right, we talked about the cardiac segments because there's going to be a segmental approach. And again, the segments are the veins returning to the heart, the atria, the ventricles, and then the outflow tracts, the arterial trunks. And each of these segments has a left and a right. And when I say left and right, I'm talking a morphologic left and right. What's really the left and what's really the right. So you can have the left ventricle on the wrong side, but we talk about left and right, we're talking about morphologic. So that's irrespective of where it actually is. All right. Now the thing that's important is those segments, veins to atrium, atrium to ventricle, ventricle to outflow tracts, they don't all hook up necessarily the correct way. So how these are related to each other can vary. So in other words, the morphologic right atrium doesn't have to actually hook up to the right ventricle. Morphologic left ventricle doesn't have to hook up to the aorta, and the morphologic left ventricle also doesn't even have to be on the left. Now, when you evaluate the chambers, and you're trying to figure out situs, the evaluation of chambers takes place in the 4-chamber view. And the 4-chamber view is an axial view. Now remember, the heart lies flat in the chest. So when we see some diagram of a heart, generally they have the atria up top and the ventricles pointing to the bottom of the page. But the way it actually sits in the baby's chest is not like that. Take that piece of paper with the drawing on it and turn it exactly flat. That's how it sits in the baby's chest. This is at the level of the 4th rib, and they've asked that about 10 times on the mock exams. I'm not sure why, because I don't know anybody who counts ribs and to get there, but keep that in mind. It is the 4th rib. 4-chamber, 4th rib. You should see 1 full rib on each side. Now, the reason for that is that in adults, the ribs kind of hang down. They start up high in your back and they kind of point downward by the time they get to your front. But in a fetus, they're not like that. They stay exactly level, which is why in the axial view, we can get between ribs. So if you are definitely axial in a fetus, you will see 1 full rib on each side, or no rib if you happen to be in the intercostal space. At the 4-chamber view, you'll see two pulmonary veins, the two inferior ones. There are two superior ones also, but that's not at the level of the four-chamber view. All right, now you'll hear the terms apical, basal. As you know, a triangle has a base and it has an apex. And the heart, which is somewhat triangular in shape, the pointy part of the heart is the apex, and anything referring to that is called apical, and anything that's referring to the base is basal. So in this picture at right, if the beam is coming in from the apex, I guess it would have been more accurate if it actually, the apex was the thing that was in the front there, but it's close. The basal is a little closer to being, perpendicular, so that's a nice shot down there. But anyway, when you come in from by way of the atria, we call it a basal, and if you come in by way of the ventricles, we call it apical. Now, the other ways you can approach it is from the sides, so a lateral view, or an axial view of the heart. And really, I'm not sure this picture is great, but really the axial or lateral view should be perpendicular to the septum. The bottom one is, the top one not as much. Now, in general, just remember grayscale images, in your 2D echo or 2D, the images that are the images that show up best are those that are perpendicular to the beam. The ones that aren't perpendicular to the beam, they kind of glance off and get reflected and don't come back. But things that are perpendicular to the beam show up the best and brightest. Doppler's kind of the opposite, which is Doppler does best when the target is moving parallel to the beam. So if you're using grayscale imaging and you're trying to get a good grayscale image of the septum, use the right or left axial or lateral views. But if you're interested in looking at the atrioventricular valves, you would like to be perpendicular to the actual valve leaflets. So use an apical or basal view. Here's an example. The one on the left is an apical insonation. This one they got right. The beam is coming right to the apex of the heart. And the problem with that is that if you're looking at the septum, you are parallel to it. Your beam is parallel to the septum, so you get that dropout. The thick bottom part of the septum blocked out the echoes returning from the thin upper segment of the septum. But if you go to a lateral or axial insonation, you can see the septum much better, and that top part of the septum that's very thin does not drop out. All right. Well, whenever you're talking about heart size, there's a couple of ways you can do it. You can either do circumference or you can do area. What we use is circumference. We put on the ellipse and we put it around the heart. We put on the ellipse, put it around the thorax. The normal cardiac circumference to thoracic circumference is a half. It's 50%. Now, this is different than heart area, where you calculate the area there. There, the heart area is 1/3, but we don't use this. So know that the heart area is 1/3, but really, so you don't get them confused, know that we do circumference, with the ellipse, and 50% is what we're looking for. This is just an interesting fact when it comes to heart size, is that if you do the heart width, the millimeters from side to side pretty much matches up with the gestational age. So if it's, 22 millimeters from side to side, that's probably about 22 weeks. All right, so now we're going to go through the chambers here. When it comes to the atrium, by ultrasound criteria, the thing that makes the left atrium is the flap of the foramen ovale. Remember, the flap of the foramen ovale came from the septum primum. The first septum that showed up between the two atrium is the septum primum. Eventually that goes on to become the flap, whereas the septum secundum was over in the right, and that becomes the foramen ovale. But the thing that's easy for us to see is the flap of the foramen ovale, and whichever atrium has that is the morphologic left atrium. It doesn't matter if it's the anterior or posterior atrium, the one with the flap is the morphologic left atrium. The morphologic right ventricle is, well, what's different about the right ventricle compared to the left ventricle? Well, one thing is it's trabeculated, meaning there's a bunch of little ridges and rough spots all over the inside wall. It's a little tough for us to see, I think. But one of these bundles or ridges of muscle is oriented transversely, and that's called the moderator band. That is very easy for us to see. The other thing that characterizes the right ventricle morphologically is the fact that the septal leaflet, the part of the tricuspid valve that's touching the interventricular septum, is a little bit more apical. It's a little bit lower down near the bottom of the ventricle there. So apical displacement of that valve. And if you look at the 4 pictures over on the right, the one that's actually a diagram and not an ultrasound picture, you can see they drew 2 lines, and the one that's across the tricuspid valve is a little bit more toward the apex. Now, and we'll go over this again later, but the tricuspid valve belongs to the right ventricle. They come as a package. So you will never have a right ventricle morphologically with a moderator band that doesn't have the tricuspid attached to it. They go together. All right. A couple other things about the right ventricle morphologically is there are 3 papillary muscles. That's kind of easy to remember because there's 3 cusps to a tricuspid, and there's 3 papillary muscles. So valve leaflet has these little stringy things called chordae tendineae, and they are attached to 3 papillary muscles. And in the right ventricle, one of those papillary muscles is on the septum. All right. Now, the right ventricle is also known to have chordae tendineae attached directly to the wall without a papillary muscle. It's a little harder for us to see that. That's one of those things that the pathologist can see afterwards, and they put it on tests for some reason over and over again. But those chordae tendineae can attach directly to the wall in the right ventricle. So basically, the wall of the right ventricle is a total mess. It's trabeculated with all these ridges. It's got a moderator band going 90 degrees from all the other stuff. You've got 3 papillary muscles, chordae tendineae attaching to the walls. All sorts of stuff is going in on that ventricle. Meanwhile, over on the left ventricle, everything's all calmed down over there. There is no papillary muscle on the septal wall. The septal wall is very smooth. And in the picture right, you have to look carefully, but there is a papillary muscle, a thick thing coming off the septum. But if you go on to the other side, it's smooth. The entire septal surface is smooth. And then, just like I said, the tricuspid valve belongs to the right ventricle. The mitral valve belongs to the left ventricle. They always travel as a package. Now, when you're looking at atrioventricular valves and you want to know what the leaflets look like, it's best evaluated in systole. So systole is when the ventricles contract. Whenever we talk about systole, we're always talking about ventricles. So when we use the word systole and we don't refer to atrium or ventricles, it's always the ventricles. So, and it's a little confusing because, valves opening make you think that something's squirting out, but actually the valves open when it's coming in. So When the ventricle contracts, the AV valves close, and when they're closed, it's easy to see them. So the picture at the left is systole. The AV valves are closed and they're easy to see, so you can see which one has that apical displacement, the tricuspid. Whereas over on the right side, where there's diastole, when diastole happens, the valves open and blood is rushing in there. It's very hard to evaluate them because you can't actually see the leaflets. All right, let's talk about a couple abnormalities, or in this case, normal variants. So things that you see occasionally, but technically may not be abnormal. So one of them is the echogenic intracardiac focus. And over the years, people have debated about whether it has to do with chromosome problems or not. And you'll see the term aneuploidy here right here. And what that means is ploidy is the set of chromosomes. U means good, and an means not. So it's a not good set of chromosomes. So that includes things like trisomy 21, where you have 47 chromosomes instead of a normal set of 46. So I got off topic there, but the whole point was, for years people tried to figure out whether this meant something in terms of Down syndrome. And when it is isolated, the consensus is no, it is not associated with Down syndrome. If there's a bunch of other things, then yes, the Down syndrome risk does increase. Pericardial fluid. In the picture over the one on the left has two arrows, and it's pointing to this little sliver right at the atrioventricular junction. And that's actually a very common place to see fluid. Now remember, there is supposed to be fluid in the pericardial sac. You've got lubrication of the ventricle versus the sac. So there's supposed to be fluid in there, and certainly during systole, when the heart shrinks a little tiny bit, it'll show up there. Typically, if pericardial fluid is normal, it is less than 3 millimeters. All right, let's talk about ventricular disproportion, where you go up to the level of the AV valves and you measure the diameter there. You can have ventricular disproportion and have it normal, but if the other thing you have to think about is that it may not be normal, and if the right ventricle is bigger than the left, think of coarctation and TAPVR. So, I don't know, certainly in general, if the amount of stuff draining into a right atrium is more because the veins are going there, that might be a bigger atrium. And if it's a bigger atrium, that means more blood's going to the right ventricle, so the right ventricle is big. All right, we'll talk about that more later in this lecture. All right, and then the other thing that we need to talk about while we're in the 4-chamber view is the retroatrial space. And I feel it's like one area that is really important, and echo experts really stress this when they give lectures and when they give tests, and we don't spend a lot of time talking about it. But we're going to talk about it a lot in the next bunch of lectures. But the retroatrial space, the space between the left atrium's back wall and the aorta, that's it. That's the retroatrial space. Now, what normally sits in there is the aorta slightly off to the left, and then you have the esophagus, which is pretty much in the middle, in that space. So the esophagus is what is actually sitting in the retroatrial space. And then off to the right of the spine by just a little bit is the azygos. Now, normally the azygos is not handling a bunch of blood, so it's very hard to see and really doesn't show up very well. But the retroatrial space is that space that leaves room for the esophagus. Now, the esophagus, a lot of times we can't see, but sometimes we can, and it kind of jumps out at us. And the esophagus is only visible during swallowing. So when the baby swallows amniotic fluid and it goes down, the tube, it suddenly gets big, kind of like the aorta, but very briefly. It's only dilated while it's swallowing, and quickly that stops. So if you see this thing jump out and you're like, whoa, what's that? Just wait a second and see if it goes away. Then it confirms, yep, that was the esophagus. All right, we're moving on to abnormal heart position. Well, keep in mind that the heart starts developing outside the body really early on in embryologic life, and it's retracted inward very early. All right. Let's talk actually briefly about abnormal cardiac axis. We said earlier before that the heart is typically at a 45-degree angle from the midline, plus or minus 20 degrees. So 25 to 65 degrees from the midline. Abnormal axis is divided into right and left. It can be either deviated more than 65 degrees toward your left side, or less than 25 degrees pointing toward the middle of the baby. Now, 25 to 65 is normal. There is a study that looked at left axis deviation, and they used a more pronounced cutoff. But basically, if you have a 75 or more degree left axis deviation, 75% have congenital heart disease. So it's a really important marker of heart disease. So yep, left axis deviation, thinking this baby probably has something wrong with its heart. Now when we talk about axis deviation, we're only talking about that when we have levocardia, when we have the heart basically in its normal spot, which is 2/3 of it in the left chest. When it's in that normal position, and that's when we can talk about axis deviation. So if it's on the right side or if it's in the middle, we don't talk about axis deviation. Now, when you have left axis deviation, and left axis deviation is more common than right, and it accounts for a whole bunch of things, including tetralogy of Fallot, common arterial trunk, coarctation, Epstein anomaly, double outlet right ventricle, so a whole bunch of stuff. Whereas right axis deviation, which does not occur as much, is typically associated with an atrioventricular septal defect. Now, I think it's just easy to remember right axis deviation goes along with atrioventricular septal defect rather than remembering all those 5 things that went along with left. Just remember atrioventricular septal defect is the one that you're thinking of with right axis deviation. Now, if you have no axis deviation, we're thinking transposition of the great arteries, and that's if it's levocardia. So in other words, if you have transposition of the great arteries and the heart is on the left chest like it's supposed to be, it won't have axis deviation. Now, that's a big if it's in the right place. A lot of times with dextrocardia, and the heart is not levocardia, you can see transposition of the great arteries. So I want to make that part clear. If you have levocardia and transposition, it won't be an axis deviation. But a lot of times transposition of the great arteries is seen in dextrocardia. All right. All right, let's talk about the heart position terms again. They're very overlapping and confusing, so let's spend a little bit of time on them. So again, we said dextrocardia is mostly in the right chest, levocardia mostly in the left chest. Now, of the ones that are mostly in the right chest, these are dextrocardias. You can have dextroposition, which means it's over on the right, but it's still pointing to the left, and dextroversion, which is it's over on the right and it's pointing to the right. And you can look at the chart on this slide to see those different examples. It's worth mentioning ectopia cordis because that is a problem with heart position, and that's where it's either partially or completely outside the chest. Now, when you see ectopia cordis, the things you're thinking about is one, something called a body stalk anomaly, or nowadays it's probably more often referred to as limb body wall complex, meaning there's abdominal wall defects, angulation of spine, also limb defects, obviously. Typically, there's not much fluid and there's a very short cord. Nobody knows how this happens, but somehow people think that it has to do with maybe early rupture of membranes, and that's what leads to all this combination of things. Now, another thing called pentalogy of Cantrell. Pentalogy means there's 5 things. Just like tetralogy of Fallot means there's 4 things. Pentalogy of Cantrell means there's 5 things. Now, these 5 things actually happen to be like all almost the same thing. Basically, as you can kind of figure, if your heart's outside of your chest, well, there's got to be some defect in the chest wall, the abdominal wall, the pericardium, and the diaphragm. And that's what it is. So we've got those things that are just defects that allow the heart to be on the outside. But then the last thing, the 5th thing in the pentalogy, is intracardiac anomalies, which is not necessarily part of the limb body wall complex. So if you've got ectopia cordis, but you don't have those other things like spine problems, oligo and stuff, and you see a heart problem, think pentalogy of Cantrell. All right. Well, again, levocardia is normal. The heart is supposed to be mostly in the left chest. Now, if it's way the heck over there, it's called levoposition. And here's some examples of basically things pushing the heart over to that side, like a big lung mass or a diaphragmatic hernia. Here, the example of mesocardia, where the heart's dead center in the middle, is an example of CHAOS syndrome. CHAOS stands for congenital high airway obstruction syndrome. So it is really, what happens is if you have airway obstruction, let's say you have laryngeal atresia, your larynx is obstructed. Well, if that's the case, your lung, the fetal lung, makes fluid. So it's actually producing fluid, and that fluid is making its way out of the lungs. So, when people are concerned that babies breathe in all this like vernix and junk that's in the amniotic fluid, actually what's really happening is fluid is being produced in the lungs, and it spends the whole pregnancy coming out. Now, if it can't get out, the lungs start to blow up like little balloons, but they're not really balloons, they're more like sponges. So basically the sponges get kind of overinflated, and when you overinflate and all those little millions of alveoli get dilated, they get very echogenic. So the thing over on the right-sided picture here is 2 overinflated lungs because of an airway obstruction like laryngeal atresia. All right. Dextroposition. Remember, dextroposition is one of the types of dextrocardia. So dextrocardia means the heart is mostly in the right side. Dextroposition means it's in the right side, but it's still pointing to the left, like a normal heart. And why would that be? Well, maybe there's something over in the left chest that is pushing it there. So it keeps its same axis, but then just gets pushed over to the right side. Examples: diaphragmatic hernia, congenital pulmonary adenomatoid malformation, or a big pleural effusion on that left side. All of those can push the heart over, but allow it to keep its normal axis. Or you can have it pulled to the right. So as you remember, scimitar syndrome was basically hypoplasia of the right lung and also an abnormal pulmonary vein that went down to the IVC in this curved scimitar shape. But the point is, if you don't have a right lung, or if it's very tiny, the whole heart shifts over. Here's some examples of dextroposition. The one they have here is a big left-sided effusion that pushes the heart way over into the right side. And yeah, same way with the other side. You've got scimitar syndrome on the far right there. And really, the reason the heart is way over there is because the right lung is tiny and the left is normal. All right, let's talk about the concept of concordance. Concordance means normally there's veno-atrial, veins to atrium. So what's supposed to happen is the IVC is supposed to go to the right atrium, and the pulmonary veins supposed to go to the left atrium. That's veno-atrial concordance. Right atrium is supposed to match up with the RV, and the LA is supposed to match up with the LV. And if they are, that is atrioventricular concordance. And then the last relationship is between the ventricles and the outflow tracts. So the right ventricle is supposed to go to the pulmonary artery, the left ventricle is supposed to go to the aorta. And if they do, there is ventriculo-arterial concordance. So a normal heart will have veno-atrial, atrioventricular, and ventriculo-arterial concordance. All right. So actually, what are the right-sided structures while we're at it here? Well, right-sided structures include the IVC, the SVC, the right atrium, the right ventricle, and the pulmonary artery. The other thing that you might not know is the right lung in all of us is trilobed. It has an upper, middle, and lower lobe to it. And the left side structures, like stomach, is usually on your left, as is your spleen, as is your aorta and left ventricle and left atrium. That one is a bilobed lung. Now, we can't tell that. The point is that all of these things can be all screwed up in different combinations. So you know what the left-sided things are, you know what the right-sided things, and you can have all sorts of combinations. So here I have what's supposed to be IVC, RA, RV, PA is switched. So what we have here is we have veno-atrial concordance, but we have atrioventricular discordance. Oh, and we also have ventriculo-arterial discordance. And you can have all sorts of combos here. All right, and here's some examples of different combos. I'll let you look at that at your leisure. All right. So how do you approach it if the cardiac position is wrong? Well, first of all, just start by labeling it, whether it's mid-chest, left chest, or right chest, mesocardia, levocardia, dextrocardia. And then systematically go through the connections between segments. And this leads us to the next chapter, which is chapter 41 on fetal heterotaxy. All right, starting at the beginning again with situs solidus, the way it's supposed to be. So There is supposed to be visceral situs solatis, and there is supposed to be levocardia, because that is cardiac situs solatis. And the picture at right shows a diagram of that, where we've got an SVC and IVC on the right, we've got a trilobed lung on the right, we've got a liver on the right, and over on the left we have a bilobed lung, we have a stomach, and we have a spleen. All right, situs inversus. Situs inversus is really just a total mirror image of everything, chest-wise, abdominal-wise. So complete situs inversus is where everything in the abdomen is exactly backwards and everything in the chest is exactly backwards. Now, you can have a partial situs inversus where either the visceral situs is a mirror image or the thoracic contents are a mirror image. So if you have one or the other, it's a partial situs inversus. If you have both, it's complete. And if it's anything besides those, it's called situs ambiguous. So if you don't have normal, situs solatis, and you don't have situs inversus, you've got something in between, and that is situs ambiguous. All right. Now, situs solatis and situs inversus, the incidence of cardiac or congenital heart disease isn't very high, but situs ambiguous, the incidence of congenital heart disease is very high. Now, heterotaxy is a term that's thrown out there, which kind of means the whole right-left thing is all messed up. And they used to be called the cardiosplenic syndromes, because what they did is they classified these individuals based on whether they had no spleen or lots of little spleens. But then, over time, it turns out the pathologist said, you know what, they're better classified by their atrial morphology, what the actual atrium looks like, because there seemed to be too much overlap with absent spleen, many spleens, so that wasn't very helpful. But the one thing that was very clear to pathologists was what the atria looked like. And the way that you can tell what an atrium looks like in the pathology lab is you've got the heart there, and the right is this kind of broad, smooth atrial appendage. Now remember, the atrium is a chamber, but it's got this little thing hanging off the side called the atrial appendage, and that's the part that looks different. The actual atrium, the actual chambers don't look very different. But the one on the right is a smooth, broad-based one, and the one on the left is a pathetic little shriveled up type of appendage. Here we've got it, you can see the actual picture of the pathetic little left atrial appendage, little finger-like, hook-like thing with a pretty narrow base. So the pathologist will use this to classify them because it's so obvious to them which it is. And you can also actually tell on echo after birth fairly easily too. But the way they tend to characterize these problems with left and right-sidedness, these heterotaxies, is left atrial isomerism or right atrial isomerism. So isomerism, an isomer is basically, a mer is a unit and iso means the same. So there are a bunch of units that are the same. So an isomer is basically like a molecule that's basically the same, but a different orientation. So the point is there are two left atrium. So they call that left atrial isomerism. And left atrial isomerism is the more common one. And with that, if you have a general two left kind of baby, you've got two bilobed lungs, because remember, trilobe was the right-sided thing. You've got two left atrial appendages. Your liver, which is supposed to be a right-sided structure, is now kind of midline. And your stomach, which is supposed to be a left-sided one, is also kind of midline. And you also tend to have more than one spleen, polyspleen. So you have a bunch of little spleens. So if you have left atrial isomerism, think of it as I have two left sides, or plenty of left sides, so lots of spleens. Right atrial isomerism is more common in postnatal series. So I just said that in a fetus, left atrial isomerism is more common, but in newborns, and they have right atrial isomerism more. Well, why is that? Well, in general, anything that's different in incidence in fetal and neonatal life means one of them doesn't survive. So it turns out that left atrial isomerism is worse for the fetus because they frequently have heart block. The reason they have heart block is the conduction system was over in the right atrium, and then if they don't have a right atrium, they may have heart block, and then those babies can die from bradycardia with high drops. So if a lot of the left atrial isomerism babies die in utero, you're going to have more right atrial isomerism newborns. All right, let's talk a little bit more about these atrial appendages. So they've got them pointed out there. And one thing that kind of jumps out at you is when you look at that left atrial appendage there have been times that you probably have suspected a left superior vena cava. So there's a little circle over there in that AV sulcus. And then we look around, we don't see a dilated coronary sinus, we see a left brachiocephalic vein, and we're like, what the heck was that? Well, it's probably just the atrial appendage, the little hunk of the atrium that hangs over the side. I had my wife take a picture of my hands here so it can help you remember. If the left atrial appendage is more finger-like, think of a glove. So I have my little L there to tell you that's the left side, and you can only make that with a glove. And then the right side is more like a mitten, kind of a broad-based, smooth contour to it. All right. So prenatal suspicion of heterotaxy. So what is it that makes you start thinking about right or left atrial isomerism? Well, looking at the atrial appendages and figuring out there's two lefts or two right may be okay for pathologists, but we can't do that prenatally at all. So what do we do? Well, here we go. The most important thing is the evaluation of vessel arrangement in the upper abdomen. We started there. We tried to figure out our fetal situs, step one, by looking at those vessels, and they turn out to be the most important part of this whole thing. And again, where are those? Well, they're in the retroatrial space, that important and informative area. And whenever you suspect a problem with heterotaxy, it's going to be primarily because you looked at the arrangement of vessels in the upper abdomen and decided that they were not correct. Once you have figured that out, then you can move on to the intrathoracic findings, but you started here in the upper abdomen. So this is a picture that's worth looking at later on your own. All right. Actually, let me go back. In general, the way it works is if what you'll look back and you're supposed to see the aorta on the left side and the IVC on the right side, and the IVC should be quite a bit more anterior than the aorta because, again, it's on its way back to the right atrium, which is anteriorly located. Now, if you go down to see, which is the aorta in its normal place, but then you have this enlarged azygos, which you normally can't see, that tells you, oh, the reason we see the azygos is because the IVC is not there. And the IVC is not there because it is an interrupted IVC. Well, when you are missing a right-sided structure, think of two lefts, or left atrial isomerism. There are two left atrial isomers. And if you have the aorta on the incorrect side, which is the right, but your IVC is in its normal place, think, oh, maybe we have an absent left and we're doubling up on the right-sided structure. So absent left, yep, the aorta is going to be over on the right side. All right. Now, situs inversus, as you can see, remember that was just a mirror image. Everything's pretty much normal, it's just mirror image. So the aorta's on the right and the IVC's on the left, but it is in its anterior position. So yeah, look at that one a lot. All right. Now, there are really two vessels coming up draining the back abdominal wall, thoracic wall. So you got your azygos slightly to the right, you have your hemiazygos slightly to the left. So sometimes when you have an interrupted IVC, that blood, it comes back by way of the hemiazygos, not the azygos. All right, so what tips you off? Well, certainly that retroatrial space that you looked for, the vessel arrangement, that's the main thing. But other things that are commonly things that tip people off is, one, the stomach and heart are on different sides. So that's a very common one. The next thing is complex cardiac malformation. So if the heart's all messed up, you should be looking for everything very carefully, and that's generally how you'll figure out that there's isomerism. And then this one's really important, which is a veno-atrial anomaly. So the veins returning to the right atrium are either messed up because there's a problem with right-sided structures, or the pulmonary veins, which are left-sided structure, they're messed up too, and they don't go into the proper left side like they're supposed to. So if you're missing a right-sided structure, think we've got extra lefts, left atrial isomerism. And if we have a problem with left-sided structure, think right atrial isomerism. And then another way that isomerism is expected is congenital heart block. So the two big things you think of with congenital heart block is, one is, anti-SSA with lupus patients, but you can have atrial isomerism where you have two lefts and you don't have a right, and you don't have the normal conduction system. All right, so in general, left atrial isomerism is two lefts and no right. That's an oversimplification. It doesn't always go like that, but tend to at least think that way. So if you've got a dilated azygos, that means you've got a missing right-sided IVC. And if you've got a dilated hemiazygos, it means the same thing. There's a problem with your IVC, your right-sided IVC. So dilated azygos, dilated hemiazygos, both make you think of left atrial isomerism. All right. You can also have an abnormal portal sinus. Remember, the portal sinus was that thing where the umbilical vein comes in and turns toward the baby's right. And if the baby has a problem with right-sided structures, it might not go that way. So, yeah, if you see the portal sinus and it's all kind of in the middle or not going the right way, start thinking, oh boy, we have some heterotaxy going on here. Now, if you see the stomach on the wrong side, the right side, just think heterotaxy. The stomach is the one thing that doesn't seem to have any bearing on which type of isomerism. You would think it would, but it doesn't. So Yeah, so stomach's on the wrong side, think, okay, some sort of isomerism, but it's not right or left. All right. So left atrial isomerism, again, one of the things that tips you off is that there's a problem with the veno-atrial connection. The IVC doesn't go back to the right atrium like it's supposed to. And if that's the case, the blood coming from the lower part of the baby's body goes somewhere else, either the hemiazygous or the azygous. And one of the things that kind of jumps out at you is the azygous and aorta basically sitting right next to each other or juxtaposed. So yeah, in the coronal plane, you'll see two vessels pretty well, maybe close to the same size. The aorta is usually bigger, but basically it looks like there's two aortas right next to each other, and that's not the way it's supposed to be. Now, it is true down in the lower part of the baby, below the kidneys, you can see the IVC and the aorta right next to each other, but in the upper abdomen, you don't. The IVC has come anterior, and you will not see it in the coronal view like this. Again, abnormal stomach position just says, hey, look for isomerism, but the real clincher is that vessels in the upper abdomen and a dilated azygos is the thing that tells you. All right. Well, as I said before, two left atrium means no morphologic right atrium. And that's where the sinoatrial node is. We're going to talk about dysrhythmias later, but if the main conduction system originates in the right atrium and there is no right atrium, there's probably going to be a problem. And usually it means a slow heart rate and the atrial ventricular rates do not match up. It's heart block. If you have right atrial isomerism, think, okay, we have two rights, so that means the liver, which is a right-sided structure, maybe we'll have a little extra liver, and we'll have no spleen. The no spleen can be tricky to figure out. Since the gray area behind a normal stomach is the spleen, well, if there is no spleen, the stomach can often be right back up against the ribs. Now here, the term juxtaposition of aorta and IVC means that they are on the same side. So whenever you see the IVC and aorta on the same side, think of the phrase juxtaposition of the aorta and IVC, right atrial isomerism. Now here they are throwing a wrench in the works. You would think, okay, good. The aorta's on the right side and the IVC's on the right side also. Great, right atrial isomerism. But then they kind of mess it up by saying, oh yeah, and it can also be both together over on the left. So the aorta and IVC are always supposed to be on opposite sides of the midline. If they are on the same side, first of all, think of heterotaxy, but specifically right atrial isomerism. Total anomalous pulmonary venous return makes you think of right atrial isomerism. The reason is, well, pulmonary veins are left-sided, and if you've got a problem or absence with the left side, your pulmonary veins probably aren't doing what they're supposed to do and go into the left atrium. They're going into the right atrium. All right, approach to diagnosis. Well, the things that make you suspicious of heterotaxy is, well, anytime there's complex congenital heart disease, you should be thinking of that. But certainly the other things that prompt these searches for heterotaxy included the heart's on the wrong side or the stomach's on the wrong side. And then lastly, fetal bradycardia. If you see heart block, think heterotaxy and left atrial isomerism. The things that we usually think of is anti-SSA antibodies that you see in lupus patients, but really remember that congenital heart defects particularly left atrial isomerism, are high on the list. Once you've suspected that, then you go to the veno-atrial connections. We're talking looking at the vessel arrangement in the upper abdomen and in the retroatrial space. And if you see an absent IVC and you see either the hemiazygous or azygous, then think, okay, we're missing a right-sided structure. I bet we have two lefts. Suspect left atrial isomerism. And if you see the aorta and IVC on the same side, it's usually on the right side in these situations, but it can be on the left, but that's never supposed to be on the same side. If you see the IVC and aorta on the same side, think right atrial isomerism. And lastly, we'll dip it in this situs inversus again. If you have complete situs inversus, that means the thoracic contents are at mirror image and the abdominal contents are both mirror images. And if it's partial and you only have abdominal situs inversus, typically the way it's described is they say situs inversus with levocardia. That tells you that we're talking chest is in the right place, abdomen's not. And if it's thoracic only and everything in the abdomen is normal, typically the term is dextrocardia. So sometimes you'll encounter a patient who says, oh yeah, my heart is on the right side. And then you're thinking, oh, I bet the stomach's on the wrong side too. And actually, no, it might not be. It could just be the chest contents. All right, when you see situs inversus, the incidence of congenital heart disease is higher. Now remember, with situs solidus, which is normal, the incidence of congenital heart disease is about 1%. And I think that was the very first slide of the very first lecture. So if you have situs solidus, the chance of there being congenital heart disease is low. It's 1%. If it's situs inversus, it's a little higher, about 5%. But for the heterotaxis, which are left and right atrial isomerism, the chance of congenital heart disease is very high. Now, situs inversus is commonly associated with something called Cartaginer syndrome, which is a single gene autosomal recessive abnormality. It's primarily a problem with cilia, the little hair-like things that line your respiratory tract. So if those aren't working right, you can get respiratory infections. They also tend to have subfertility. But overall, Cartaginer's has a very good prognosis. And that's it for today.